cái phần trình bày của giáo sư thì chúng tôi cũng có trao đổi, thì giáo sư sẽ nói chậm bằng tiếng Anh, và đồng thời chúng tôi cũng sẽ có cái phần dịch bằng tiếng Việt ở trên bảng ở dạng subtitle, cái dịch song hành, chứ chúng tôi không có dịch đuổi. Thì cũng mong quý đồng nghiệp cố gắng theo dõi và thông cảm.
Xin chào quý vị. Tên của em là Cameron Smith. Em rất hân hạnh được nói chuyện ở đây và biết ơn cho Bệnh viện Đại học Y Dược và thầy Đức, cô Trúc, bác sĩ Thảo để có cơ hội nói chuyện với quý vị. Xin lỗi vì cái tiếng Việt thì không đủ để nói suốt bài bằng tiếng Việt, nên sẽ nói tiếng Anh. This is the state that I'm from, right in the center of the country. I'm from this area right here, Kansas City. We're known for our football, for barbecue, and some of the World Cup matches will be there in 2026, so look for Kansas City when you watch the World Cup. I'm here in part on behalf of RAD-AID, which is an organization of radiologists that was founded in 2008 with the mission to help advance radiology services around the globe. It's an honor to be a part of this organization that does great work all around the world. And these are just some of the pictures from around the world of volunteers helping to teach radiology and progress radiology services in all different modalities, as well as in interventional radiology. This is the health system that I work for. It's a large health system in the Kansas City area. Our Department of Radiology is pretty large, and our section, the breast imaging section, there's 8 of us in our section. We have 1 fellow usually and 2 to 3 residents per month. So to get on with my talk, today I'm talking about neoadjuvant evaluation of breast malignancy. And I won't spend very long on this. Dr. Gould did a great job talking about the purposes of neoadjuvant chemotherapy, and there's a lot of overlap between our 2 talks today. So the purpose, we were trying to achieve a pathologic complete response, and this is for multiple reasons. It allows us many times to do breast conservation surgery when otherwise we wouldn't be able to. We're able to downstage the axilla to de-escalate surgery, as Dr. Gould talked about. That's a big trend in breast cancer care, is de-escalation of surgery. And those who respond well have improved prognosis, so it's also helpful for us in understanding prognosis. So this is just a case to point out a classic example of the importance of neoadjuvant chemotherapy. This is a 43-year-old female with triple-negative breast malignancy, and as you can see, if I can do this. Perfect. As you can see here, this is the classic findings of a triple-negative breast malignancy: a round, large mass, circumscribed margins with some internal central necrosis. So this patient underwent neoadjuvant chemotherapy and had significant decrease in size of this tumor. The classic findings for a triple-negative breast cancer are radiologic complete response, where we see nothing. This patient went on to have additional cycles of chemotherapy. But as you can see in this 3D reconstruction, this took up a significant portion of this patient's breast. It would be very difficult to achieve a good cosmetic result in a patient trying to undergo breast conservation therapy with a mass this size. But with the shrinking of this tumor and additional rounds of treatment, this patient went on to have a pathologic complete response with significant smaller size of the tumor bed as compared to the initial imaging. So as radiologists, and the model that's helpful for all of us in talking about and across all the different areas of the hospital, we frequently use the RECIST criteria that I'm sure you're familiar with. And those are broken down into these classifications. Again, I'm sure you're familiar with this. The complete response being that we've removed all the target lesions have disappeared completely. And then we can call partial response as long as there's at least 30% or greater decrease in the size of the masses that we are targeting. And sometimes we will apply this to just the breast. Some studies have applied this to both the breast and the axilla. I'm not aware of any guidelines that restrict one way or the other, so typically in my role, I'll just describe what's going on in both places, the breast and the axilla. So it used to be that we thought that breast cancer was just one single entity. You have breast cancer. This is decades ago. But we know now that this is certainly not true, that there are many breast cancer subtypes, and even in a single patient's tumor, there's a lot of tumor heterogeneity, the actual clonal heterogeneity of the tumor cells. And this was work that was really started by Peru et al. In the Nature 2000 article, Molecular Portraits of Human Breast Tumors, where the heat maps for these genomics were put forth and were able to understand that these molecular subtypes of breast cancer exist: the luminal breast cancers, the HER2 overexpressing breast cancers, and the basal type breast cancers. And we have IHC surrogates that we use now to know which type these are without necessarily having to do the genomic studies. So as you know, the luminal A breast cancers tend to be very strongly hormone positive and HER2 negative. The luminal B cancers, less hormone positive, typically HER2 negative, but they can be HER2 positive. These are typically also have a higher Ki67. And then we have HER2 overexpressors, our hormone negative and HER2 positive cancers, and then our basal type or our triple negative breast cancers. And this has huge implications for treatment and prognosis and even for imaging. And so that's what I'll talk about here, is some of the imaging findings of these different subtypes of cancers. So for our luminal cancers, these are our what we call the most common or garden variety breast cancers. They're less commonly multifocal or multicentric, though certainly they can be as they become more advanced. The luminal B cancers are more likely to have that axillary nodal involvement, in part because they're more aggressive nature. The higher Ki67 indicating that more aggressive tumor. And typically, if they do have metastases, they're more common to have bone metastases, especially in luminal cancers. Our HER2 overexpressing cancers are certainly more aggressive. They're more likely to be multicentric and multifocal. And often you're going to see the metastases to the axillary lymph nodes in these cases. And then our triple negative breast cancers, again, we talked about this, these frequently present as a rapidly growing mass. And these can sometimes even appear what looks like benign on some imaging. And so Dr. Koop already talked about some of the ways that we can have assistance through ultrasound and other means to help us to know, even when it looks benign, that this is really a malignant process. These frequently show central tumor necrosis because they grow rapidly. Usually they're unifocal, they can be multifocal, they're not typically multicentric. Our recurrence risk is greatest for our triple negatives in the first couple years, and then later for our luminal cancers. So who should get preoperative MRI? We can consider MRI when the tissue of the breast is very dense, or we have uncertain extent on mammography and ultrasound. Is frequently helpful in invasive lobular carcinoma, especially because other imaging modalities tend to undermeasure the invasive lobular carcinoma. The same with DCIS. When DCIS has a large extent or is higher grade, MRI can be very helpful to know the true extent of disease. And then if you know you're going to be giving neoadjuvant chemotherapy, then it's very helpful to have the pre and post neoadjuvant chemotherapy imaging. Obviously, there are additional indications, occult, primary with axillary metastases, negative conventional imaging, but in the setting of neoadjuvant chemotherapy, these are people that we can consider. So why MRI in this setting? It's got the high sensitivity for determining the extent of disease, for assessing residual disease and predicting pathologic complete response after our neoadjuvant chemotherapy. Again, this is very important, especially in ILC. It can overmeasure for DCIS because DCIS frequently enhances much less. It can be easy to get confused between the background parenchymal enhancement and DCIS. But other modalities may struggle to distinguish between fibrosis or post-biopsy change in cancer, and I have a case of that coming up here. The correlation coefficients between tumor sizes on imaging and histopathology are best for MRI. So lowest for mammography, but best for MRI. So we get the best true information of what the tumor size really is. And of course, it guides us for surgery and systemic therapy. So this is an ultrasound case of a patient with a left breast malignancy at 7 o'clock. And here's the malignancy prior to treatment. And then after treatment, you can see that this tumor has shrunk significantly, but there's still some of this different appearance of the soft tissue surrounding the biopsy marker. So the question becomes, is this soft tissue malignant or is it just fibrosis after care? And it's very hard to tell on ultrasound. That's what the MRI helps us to do, is identify, is there any really residual enhancement, because we get physiologic information, not just the anatomic information. Again, same thing here. On the top here, we have the pre-treatment and then post-treatment at the bottom. And again, it's harder to tell on ultrasound if this is just fibrosis or true residual disease. This is a famous chart from Husami et al. In 2012 that looked at who tends to get pathologic complete response. They looked at both the breast and the axilla, and also just looked for only the breast only. But the point here is that those that are hormone positive, our luminal type cancers, are least likely to achieve a pathologic complete response. And those that are not hormone positive are much more likely to achieve the pathologic complete response. And this is old data, so certainly, especially with the more modern treatment regimens that we have now with the biologics and immune modulation therapy, we're seeing even higher rates of pathologic complete response in our HER2 positive and triple negative cancers. Again, this is data from that same article, just showing that our HER2 positive and hormone negative cancers are much more likely to achieve pathologic complete response. This is a busy chart, but there's data that has looked at how well does MRI predict pathologic complete response. So when we say that there's radiologic complete response, how well does that predict true pathologic complete response? This chart is a little bit easier to digest. So basically what we see here is that for the negative predictive value, which means when I say that there's residual disease, if I see enhancement and say there's still cancer in this breast, MRI is very good at that. So we see high rates of negative predictive value for MRI in predicting that there's still residual disease. It's not as good at predicting pathologic complete response, and especially in those cancers, again, that are hormone positive. So our hormone positive cancers have the least accurate prediction of pathologic complete response by imaging. An important caveat to understand with a radiologic complete response is that even if a tumor shrinks, if there are calcifications associated with the malignancy, we need complete excision of those tumor bed calcifications because of the high rate of persistent malignancy associated with those calcifications, especially DCIS, because frequently our neoadjuvant chemotherapy doesn't adequately treat the ductal carcinoma in situ. So here's a case of a 69-year-old female who had some screening detected calcifications, as well as this asymmetry that you can see here. Here's a larger set of images where hopefully you can see some of these calcifications here measuring up to approximately 5 centimeters. So on the MRI, there was a clear invasive component with a mass, and after neoadjuvant chemotherapy, this had shrunk significantly, and there was really no residual enhancement. And so in terms of the MRI, we had radiologic complete response. But because of the residual calcifications, this went on to have a bracketed localization. These are radioactive seeds bracketing the extent of these calcifications. And on the final pathology, we saw that there was indeed still ductal carcinoma in situ in this area, and this is very common. And so even when there's a radiologic complete response, the calcifications still need to come out. And you frequently see that the overall cellularity of that tumor bed is very low, but if you leave those calcifications, you essentially will leave behind some of that DCIS. So our imaging pearls or our tips would be for our hormone-positive disease, it's very common to see residual nests of tumor cells. Dr. Vu had a slide that showed the different patterns, and on his slide it talked about the crumbling appearance, and that's the same thing. The residual nests of tumor cells are especially common here, and these frequently show ductal carcinoma in situ, but it's easy, you can also have the invasive cancer in those areas. Our triple negative and HER2 positive hormone negative cancers show the strongest correlation of radiologic complete response and pathologic complete response. And our MRI positive predictive value is highest, so highest for predicting highest for predicting a true pathologic response in triple negative breast cancers and our HER2, but lowest in our hormone positive cancers. And we have to be aware as radiologists that sometimes that fibrosis, as the tumor is treated, the resulting fibrosis and sclerosis of the tissues can enhance, especially on delayed imaging. And so we have to be careful not to overcall that. These will be some cases of different types of cancers and their appearance on neoadjuvant chemotherapy. So we have a luminal A cancer in a 67-year-old female. The biomarker is consistent with this luminal A diagnosis, and she also had lymph node metastases. So here you can see this large mass in the upper outer quadrant of the right breast, as well as some of the axillary nodal disease. And here's additional images of the axillary nodal disease in this patient. So she went on to have neoadjuvant chemotherapy. And you can see here that the overall size of the enhancement is not significantly changed, but the bulk of the tumor has decreased. And you can see these foci of enhancement, that crumbled appearance or residual nests of tumor cells in this area where we had treated tumor. The lymph nodes have also responded well. So these residual nests of tumor cells are common for hormone-positive disease. And although those lymph nodes have decreased significantly in size for our hormone-positive cancers, it's important to remember that we have a hard time predicting pathologic complete response. And so even though the lymph nodes look better, it's not uncommon to have residual cancer in the lymph nodes. And that's what happened in this case. We had micrometastases to our sentinel node, and then on the dissection, multiple of the lymph nodes showed micrometastatic foci. And the mastectomy specimen showed residual IDC as well as DCIS. So this is a very common pattern for our luminal cancers. This is a luminal B breast malignancy, so lower hormone sensitivity, still HER2 negative. And again, this patient also had axillary nodal metastases. So here, again, a large mass in the upper outer quadrant. And after neoadjuvant chemotherapy, the same idea of these residual nests of tumor cells, residual areas of enhancement throughout the tumor bed. And again, this was consistent with residual invasive ductal carcinoma in the setting of treatment effect, as well as ductal carcinoma in situ. So again, a reminder that for our hormone-positive disease, residual nests of tumor cells are very common. This is the common pattern that we see. For our triple-negative breast cancers, these tend to respond very well. So in this 45-year-old female with a mass in the outer right breast here, at the end of treatment, she had significant decrease in size of that tumor with no residual enhancement. So this was a radiologic complete response. Our pathology was also consistent with a pathologic complete response. Finally, our HER2 overexpressing breast cancers. As we talked about, these are more frequently multifocal or multicentric, and that's what this case showed, as well as axillary metastatic disease. So you can see extensive left breast malignancy here with multifocal disease. However, following neoadjuvant chemotherapy, all of the area of enhancement has resolved, although there are these new areas of enhancement that were not there before that we'll talk about. And they're not just in one breast, they're in both breasts. And this is, again, a common finding for those who have been treated, especially with our immune modulating therapies. So here are those areas of enhancement that are new in both breasts. It's very uncommon to have new sites of disease on neoadjuvant chemotherapy. So as radiologists, we don't want to overcall new disease. And then these areas are associated with cysts. Does anyone know what these are? These are inflammatory cysts. And so these are a common finding in the neoadjuvant treatment setting for those who are receiving immune modulator therapy. We don't know exactly why, but we do see this commonly, inflammatory cysts in this setting. So the axilla prior to treatment in this patient, you can see large lymph nodes in this area. Following treatment, significant decrease in size. These are essentially a radiologic complete response. And on the final pathology, we did see some residual ductal carcinoma in situ, but other than that, there was no invasive carcinoma, and all of the lymph nodes had responded well. So as I had just mentioned, inflammatory cysts in the setting of immune modulator therapy are relatively common. Here's a patient who has multiple bilateral cysts, and one of those cysts is showing avid enhancement around the cyst. So is this suspicious? No, this is just part of what we can expect with treatment on these patients. Finally, I wanted to talk about MRI and CEM in the neoadjuvant setting, as CEM is relatively new and upcoming. So in a 22 study, prospective study with a small group of patients, they found that the CEM and MRI, and they also looked at delayed CEM, had fairly good correlation between imaging and pathology. So the delayed contrast enhanced mammogram did slowly overestimate the residual disease, and that's because of that fibrosis. So the fibrosis will enhance. But the difference was in, essentially 1 or 2 millimeters, so not too significant. And there's a strong correlation between the imaging and pathology size for CEM. RECIST response criteria is good on CEM just like it is on MRI, and the sensitivity and specificity are fairly similar, slightly better for MRI, but fairly similar. And so this is an area of developing research, but we do use, at our practice, we do use CEM for many of our neoadjuvant patients when it's appropriate. MRI is still preferred, especially if there's axillary metastatic disease, because you're not going to see that on the CEM. But many patients qualify and can be followed with CEM instead of needing additional MRI. Doing delayed phase on a CEM can be useful for especially in cases of DCIS and ILC. So these are just some cases of CEM neoadjuvant chemotherapy. This was a 48-year-old patient with a luminal B right breast cancer. You can see the cancer here as well as a satellite. There's an additional area of enhancement here that went on for ultrasound, nothing in the left breast. And so after neoadjuvant chemotherapy, we have a radiologic complete response. And this additional area was just a small fibroadenoma. So both radiologic complete response, and it predicted well the pathologic complete response. One more case. So this patient had a MRI initially showing this mass in the right breast, central right breast, after neoadjuvant chemotherapy. You can see even though there's a lot of dense breast tissue, that dense breast tissue is essentially masked by the subtraction process. So we're left with just the areas of enhancement in this breast, and there's no significant enhancement. So we have radiologic complete response, which again predicted well the pathologic complete response for this patient. So in summary, MRI provides the most accurate non-invasive estimate of residual disease after neoadjuvant chemotherapy. It helps with treatment decisions for surgery, for oncology, for radiation oncology, and for prognosis determination. Interpretation and accuracy are heavily influenced by the tumor subtype. So it's very helpful when we're reading as radiologists our cases, knowing the tumor subtype to be able to discuss and predict the behavior of that tumor in the breast. Future directions, as Dr. Wu talked about, someday for these patients that have a radiologic complete response, it would be wonderful to not have to excise those areas and reduce the morbidity that comes from that. And that's going to rely heavily on radiomics in the future. Xin cảm ơn.
Thank you so much for your presentation. Bây giờ chúng ta đến xong 3 bài báo cáo rồi, chúng ta sẽ có thời gian nghỉ giải lao là 15 phút ha. Vậy thì mình sẽ giải lao cho đến 15:30 chúng ta sẽ bắt đầu lại nha. 15:30. Có thể đặt câu hỏi ha, ở đây hoặc là ở ngoài kia gì đó, tùy gặp báo cáo viên, các bạn có thể đặt câu hỏi nha.